Hello, everybody. I think now it's time to start our next seminar, I3h seminar, where I will briefly introduce Philippe BEUTELS. Philippe is a professor at University of Antwerp. He's the founder and director of the Center for Health Economics Research and Modeling Infectious Diseases. He's also the founder and co-director of the Inter-University Simulation Models for Infectious Diseases Consortium, which he runs together with Neil Hens, who gave a seminar in the fall. Philippe is a specialist of health economic evaluation, of models of infectious diseases, of the economics of infectious disease prevention and control, and on criteria for healthcare prioritization. He's a very well-cited and well-known specialist who started out as an economist. He did a master in commercial engineering in Antwerp and a PhD in medical sciences on health economics. He's held position beyond Antwerp also at the University of Sydney and the University of Technology at Sydney. He's been a regular advisor for national international institutions, including he's a member of the Superior Health Council of Belgium, a member of the Royal Academy of Medicine of Belgium, and a former member of the I3h Immunization and Vaccines Related Implementation Research Advisory Committee of the World Health Organization. He's very, very active, and I'm only giving you a subset of what he does. He's published hundreds of papers, and my connection to him is that we are both members of the GEMS, together with Neil Hens. And of course, he will talk about health economics and well-being in pandemic times. And it's great that you're here to enlighten us. We are all ears, being people quite interested in interdisciplinarity, with people from economics, management, life sciences, and so on. And so we will be extremely interested to listen to you. Thank you, Philippe.
Thank you very much for this very nice introduction. As you said, as Matthias indicated, and thank you also for the invitation to speak at this series. I think it's really interesting that the interdisciplinary exchanges that take place with the pandemic. It's a big challenge, the pandemic, but I think it has also been an opportunity for people to work together who hadn't previously done so. So I will talk a bit about health economics and well-being. Actually, this is one of the few slides that has some Dutch on it. Most of the slides are in English, but this is our center. As Matthias indicated, I founded CHERMID, the center, and the CIMID consortium. And so it started very much as with one person or a few persons, and then it grew until we are now with a sizable group of people who are working on different topics related to infectious diseases from different angles we look at it. So mostly health economics, mathematical modeling, and biostatistics. And we usually have people with different backgrounds in our group. So many people in our group have dual qualifications, but we work with people who've done physics, mathematics, engineering, of course, medicine and immunology, also statistics, economics. And we used to have a philosopher, but he has moved on to another university. So I'll talk about three things today, mainly health, and that's the first part. I'll talk about the health impact, and the other two impacts, I'll talk about macroeconomics and well-being. as part of the current pandemic, of course, and a little bit of history also, looking back. So the core of the problem is, of course, the physical context. As you know, it enables transmissibility, and it increases what we call the force of infection. So the probability of becoming infected when you are susceptible by unit of time. So that is directly related to the physical contacts. And therefore you have impact on health, disease and death, and on the health system and the capacity of the health system. And that's the first part. I'll talk very briefly about that, and also historically about how we developed this in our group. Perhaps that can be also of interest. And I'll talk first about contact research, and then on some of these other aspects related to serological studies, projections that we do in models, and hospitalization capacity. So historically, I started becoming interested in the contacts research as when I started looking into the impact of infectious diseases and modeling the spread of infectious diseases. When I first started, it was the early 1990s, and most economic evaluations of, for instance, vaccination programs basically assumed that an infectious disease was just like any other disease. So there was no communicability associated with infections. They used what was called static models. And there was a small group of people who had links with economics that were looking into contact data. And one of them was John Edmonds, who's currently at the London School of Hygiene and Tropical Medicine. In those years, we started looking into dynamic models where you have the dynamics of the transmission incorporated into the model. And those dynamics are driven by social contacts. So we started doing research in, trying to estimate social contacts, estimate physical contacts. And we did this in a number of pilot studies, and using a diary-based approach. And first of all, you need to, of course, define what are at-risk events for transmission in terms of physical contacts. And those days, this definition was set forward, and that's what we're still using today. So this is about two-way conversations where multiple words are exchanged between individuals without raising their voice, and touching. So it can be either with or without conversation, where you have a skin-to-skin touch. This is a general definition, but we have more specific definitions when we are looking in different infections, like hugging and kissing, or sharing a closed environment. So we have people gathering in a closed environment, typically a classroom or a bus, where there's not necessarily a conversation or touching involved, but where there could be an at-risk event. So we're trying to document these things in order to parameterize simulation models. And so this is the first Belgian study that was done on this. And you see that there's a big influence of age in terms of the proportion of contacts that can be recorded. And clearly there's a peak that we observe here in these pilot studies. You could see it right from the start, and later that was repeated in bigger studies, of course. I'll come back to that in a second. So what these diaries mainly present to the respondents is like you have to record on a random day that is assigned to you. You have to record all the contacts that you have with other people. And sometimes you will know the exact age of the person you're contacting. So that's given here, where you have in the first column an age that you can give exactly or with a range if you don't know. For instance, you don't know somebody who owns a shop that you have a contact with. You don't know their exact age, but you may know, you may estimate their age range. And the same goes for these other things where you have gender that you can indicate, whether or not you touch them, how often you contact this person, how frequently those contacts occur, where the contact occurred, so home, school, work, transport, and so on, and the total time spent over the day with that particular person during contact. We also collect, of course, background information on respondents, and we relate that also to childcare use data and so on when we compare countries. So there was this big European project that we set up, and it was called Polymot. And this is the most sort of the mother paper of all social contact surveys, where you see these heat maps of who has contact with whom, and with a strong diagonal image that is the same across these different countries. And let's have a look at Belgium for a minute. Of course, people of the same age have more contacts with each other. There's also an intergenerational pattern that you see on the side here to the off diagonals, mostly parents with their kids. So the lighter the map, the more intense and the more frequent the contacts are. There's also a slight grandparent aspect that you see. And this is also shown on the left side in the contour plot. You can see that why it's so important to understand the drivers of transmission, why the younger 20-something people, people in their late teens and 20-something, you have this huge peak in the frequency of contacts in normal times these people make, and they're a huge driver of infections that are invading a population when the whole population is susceptible. And this is, of course, a key understanding what's driving an emergence of a new pathogen in a population. These social contact patterns have a key feature of how this emergence occurs. Now, early in the COVID pandemic, we decided to publish and make available all these social contact data so people can, from previous publications, it's called Socrates or Socrates, where you can access contact data online. There's a publication that goes with it. We also did earlier a systematic review of social contact surveys for background, and there's an overall website where social contact data can be consulted. This as a background. So these data are important if you want to model the spread of close contact infections. And in these type of models, we typically, of course, include all this general information of a particular infectious disease, such as you see here for SARS-CoV-2. So that's based on international literature, and that kind of information is a bit universal to some extent. But this is combined with local data on social contacts. Now, when early in the pandemic, Roy Anderson is somebody to mention. He's a sort of the grandfather of my generation of infectious disease modelers, showing qualitative illustrations of basic options that we had when there was an invasion. And of course, you could do nothing and then you have a very high peak. And that's quite easy to model, of course, in a fully susceptible population. But it would not be realistic, because as there's an emergence of a pathogen, there will be behavior change. So it will be more like the green line, where people start to voluntarily adapt their behavior in terms of physical contacts, but also, and everything that's linked to that, like for instance, consumption. I'll come back to that later in the talk. But that's a much harder line to model if you want to do it, want to get quantitative estimates of that. That's much harder because if you don't know what, how, and to which extent and how rapidly people will change their behavior under the influence of an emergence in the population. But it's quite certain that qualitatively it would have looked more like this. And what happened is that we had a lockdown where you had an imposed behavioral change on the entire population, and risk of resurgence following lifting of intervention. So this is what was published in early in the pandemic, and of course it was completely right that those are the main options that we have, and the main dangers also, where you have the risk of resurgence if you lift interventions later on, and behavior doesn't change permanently, or you don't have enough ways to control the epidemic. So one of the things we started doing is to record contact data throughout the pandemic. But I understand my colleague Neil Hens has already talked in this series, so I'm not going to talk too much about modeling, and going swiftly through these slides, just to mention that we do see in the different waves, the different stages of the pandemic, we do see clearly a change in physical contacts, also given the measures that are changing over time. But what we see compared to the line on top, this is what happened in pre-pandemic times in terms of the number of physical contacts in different age groups. You can see we stay well below that in all age groups through all stages of the pandemic. So there is an adaptation, and the adaptation, of course, is mostly when people go outside their home. And there's a paper that you can look into if you're interested in that sort of data. I'm also not going to talk too much about this. This is one of the models that we've been using to make projections. In our group, we had 4 models. What it basically comes down to is that this is a compartmental model. So you divide the population in different compartments. You describe the flow between compartments through a set of ordinary differential equations. And at the core of this is this lambda, the force of infection, that governs the transition of from the susceptible compartment to the exposed compartment. And lambda, interestingly, is of course proportional to the beta, the transmission coefficient, which in its turn is proportional to the contact rates between people of different age groups. So the contact data are very much at the core of these estimates. And these models that we use is dynamic in the sense that there's a feedback mechanisms that is informing the lambda over time as the infection is spreading. The lambda is influenced through how many other people have been exposed in the population, and what the probability is of coming for a susceptible person to come into contact with an infectious person. So this changes under the influence of time and under the influence of contact behavior.
Can I maybe ask a question, Philippe? And by the way, yeah, I forgot to say that, but questions are welcome. Philippe said.
Yes, yes.
So yeah, in terms of the, as you say, a key question about the impact of the virus and lockdown is the extent to which people change their behavior accordingly because they fear that the virus is circulating a lot, which of course has an impact on the cost of a potential lockdown. You know, best example, I think, in people talk always about horeca being closed. It's not true, of course. Horeca is closed, but the hotels are not. But you go to Brussels, the hotels are empty. So that's, you know, pure demand. Of course, restaurant will say, oh my God, if we are closed, it's a disaster. if we are open, we will be full. Now, I think there is a difference between hotel because, you know, Chinese and Japanese tourists won't come even though the hotels are open, while Belgians may be less worried. But still, to what extent for your, let's say, behavioral parameters, is there a discussion with some of the, let's say, straight macroeconomics analysis done? You know, people talk always about this project by Chetty and others in Harvard. Is there a dialogue? Are you using some of their things to feed into your models or not?
At the moment, not. No, we're using mostly this type of information that we collect in Belgium, and the main reason was speed, of course, and you can see the dates that we're collecting this information is given here in the legend. And we also see that internationally there are some differences between countries in you know, how the population is adjusting their behavior. It differs depending on the context and the demography of the population. So when we make projections, we have to assume have to assume a forward change in behavior, but that is very much informed on scenarios that we make rather than observations that we have to feed into that. What Chetty has been doing is mostly also looking back at what happened and interpreting that. And we try to do that with this social contact research, see how people have adopted their behavior in the first wave, how it is sustained over time, and then we can derive from that some scenarios for the future. And depending on the structure of the model, this can be in more or less detail. So we have different models that we apply, and they have a different structure, each of these models. We think it's important to do that, so not just have one model, but have different models with a different structure to account for the uncertainty associated with imposing a structure in the model. And I was just briefly going to say that this is one type of model. It's where you have a compartmentalization of your population. You have it's not the individual-based model, but it's by compartments. And when we apply this model, we calibrate it to observations. This is the solid dots here. These are observations of hospital admissions over time, and by changing mostly the social contact data, we can fit this curve. And by up until a point where we say where we have data to fit to, and then we can try to project forward and validate what we project by new data coming in, up until a certain point where we say, let's now model scenarios. And this is what we do with this model from this time point. Somewhere in May, we said, let's do a number of scenarios. This is available online also, and is being peer reviewed at the moment. Another thing that we fit to, in addition to observed hospitalizations, is also seroprevalence, because hospitalizations is the result of a clinical manifestation. And a very important aspect of the transmission of infections is, of course, what happens under the surface. People get infected, and many people don't get symptoms or get mild symptoms. They don't go to hospital. So we have to make sure that these models also have that information in them, and that has also been challenging. Because people lose what we typically measure in serological studies, they lose that fairly quickly. So the neutralizing antibody levels are fading over a matter of months. And so what we do is we compare periods that are not too far apart from each other to derive from the seroprevalence data, so the presence of antibodies in serum from residual samples that we collect through big laboratories, and we compare that over consecutive periods, and from that derive the sero incidence. So over a particular period, we can estimate how many people in each age group have incurred an infection, and we use that information also to fit the model. But then when we have fitted a model, we have calibrated it and we try to validate it, we can try to make projections. And we've been cautious at not making too long-term projections, but because the uncertainty, of course, is very, very large. But this is an example of a projection that was made. So this is still the compartmental model that I mentioned earlier, mostly the work of Steven Abrams at the universities of Hasselt and Antwerp. You have a different scenarios where you say, let's assume that the work and transport contacts that normally occur in pre-pandemic times, you still have 30% of those. In this scenario, we have 0% school contacts, so the schools are closed, and 20% of the contacts that we would have in leisure time versus normal times. And then you change these percentages and then you can make projections. And what we saw in this type of models is that leisure contacts are very, very important. As you can see here, as it increases up to 40%, you get an increase here, even when schools are closed. And the whole range of scenarios were done. This is actually a scenario that illustrates this. I think it was done somewhere in June that we made this projection, or half between May and June. I don't remember exactly. It's in the paper, but that mimics actually quite well what qualitatively, of course, what happened in reality, and it shows that these explorations show that the schools didn't have a major impact given the assumptions that we made about the social contacts, and most of the explanation was in the leisure time for most of the time. But as I said, I'm not going to dwell too long on the models. We do also have an individual-based model where you model all the individuals in society. The principle is the same. There's a calibration phase and fitting phase, and then a projection under uncertainty. So the uncertainty here for the projection is the gray area. So this is all possible, given that in this case we have open contact bubbles. This individual-based model could be used to test the hypothesis that open contact bubbles are much worse for the epidemiology than closed ones, where you have fixed contact bubbles over time instead of changing them each week or each month. In this case, this was changing each week, the contact bubbles. You can see that you have a much higher probability of getting a resurgence in the infections in this model. This is also a model that can be found online. Moving away a little bit from modeling, so this is one thing that we try to do, and this is mostly under direction of Neil Hens, as was mentioned. He's coordinating all these different models. We're also looking at healthcare surge capacity, and by relating the number of hospitalized patients and also the number of deaths with the hospital capacity at a certain point. This is what we've done in this paper, where we looked at the point in time in the first wave where Italy's healthcare system got overwhelmed in March. And we used that as a kind of a benchmark to look at a point where the countries that would follow Italy would have a similar experience in terms of being overwhelmed in terms of the hospital capacity. And we looked at this in two ways. It's the intensity approach and the magnitude approach, where we relate the capacity in terms of physicians and nurses and critical care beds, or physicians only and critical care beds in blue, to the mortality observed in the last 3 weeks. Mortality being, at that point, we thought is a very comparable outcome between countries. We knew there would be problems with the detected cases and all of that in order to compare them because of the testing intensity. Unfortunately, hospitalizations were at that time not fully available, but we tried to use what we could find in terms of reported active cases in hospital. This is what I took from our website. It's still active, this website. It updates this information every hour, more or less. This is from the 13th of January, where you could see that there was pretty high pressure in these countries in terms of the intensity and the magnitude, also particularly in the United Kingdom and Ireland. So we try to see how under what relative pressure these different systems are, because we know that basic healthcare capacity is a key in determining the outcomes of patients, both COVID patients and non-COVID patients. If you create extra capacity to deal with a pandemic, that can help, of course, but you cannot move away from the fact that your base capacity determines very much what you'll be able to do. You can only add so much to your base capacity in order to deal with this urgent problem. And that's why we also wrote this recent viewpoint where we say, ceci n'est pas un lit. Base capacity healthcare is a key issue in pandemic times. It was also illustrated for Belgium in this paper, where this comment is actually related to, where they could see, in addition to well-known things like age and the availability of certain equipment and measures, they also noted overflow as an important determinant of survival in ICU of patients admitted with COVID. So this is for Belgium. And overflow refers to the additional capacity being overwhelmed, so that you have to use more of your additional capacity instead of your base capacity to deal with the problem. And this gives worse outcomes in patients. So base capacity is very important if you want to deal with a pandemic. And so investing in pandemic control begins before pandemics occur. And this is very reminiscent of when you look at the problem in terms of macroeconomic impact. Prevention starts long before that. So quite some time ago, you have to understand in health economics, there is the general tendency to look only at costs that are occurring in the healthcare system. So when they are looking at whether or not they're reimbursing new medication or new therapies, most reimbursement systems are focusing on the direct healthcare costs for the system, as well as the health impact in terms of quality adjusted life years for the patients in question. And for most interventions, this is fine. But for infectious diseases, and particularly, of course, pandemics, this is totally wrong. because there will be a huge impact on outside of this small part of the economy. Well, relatively small, I should say, the healthcare sector. So outside of the healthcare sector, you will have big impacts related to behavioral changes and capacity problems that will occur. So in that particular paper, we said, look, if you want to value prevention to deal with pandemics, you have to take into account much more than what we usually do in health economics. And this has to do with the valuation of infrastructure, but also with the evaluation of therapies like antiviral drugs or vaccines. There's a much broader impact that needs to be accounted for. Continuing on that theme, we also looked at what happened in Beijing with SARS, in comparing a year-by-year change. 2003 is when SARS-1 occurred versus 2002, the year before. You can see the shaded area is the SARS cases occurring in China, and the red area, the deaths. You can see that has a big impact on all these indicators of economic activity or activity in general. Not all of these were imposed, so some of these were voluntary. And you can see of course, China was growing at a very high speed. The economy was growing very rapidly. You can see how that growth declined during this crisis to a very low percentage. It was still growing, but not that quickly anymore. So that just demonstrated that there was this extra impact. And we also tried to model this to some extent using a computable general equilibrium model. Also for Belgium, this was in 2008, where we used different scenarios of impact. So for instance, we had school closure for 4 weeks. We had prophylactic absenteeism of 1 week and school closure for 4 weeks. And then we had school closure for 13 weeks. And this is actually what occurred in the COVID pandemic. We did have school closure for 13 weeks. And to give you an idea, we estimated for the scenario, we had 13 weeks school closure and 4 weeks of labor interruption, productivity losses associated with the general estimate. We came to 5 to 7% impact on GDP, which is more or less the annual impact observed in the current pandemic. But when we were making these type of studies, we had lots of skepticism to deal with, because most people were saying a 13-week school closure, that's just not gonna happen. That's unrealistic. Well, yeah, we know that it was something that was a possibility, unfortunately. And what we didn't explore in this paper is that we didn't look at the difference between voluntary behavioral change and imposed behavioral change. We just modeled the consequence of a certain behavior change without looking at whether or not it was voluntary. And that is, of course, a limitation, because it's very hard to tell what voluntary behavioral change would be. And we now know that the National Bank of Belgium is estimating the impact of our second wave much lower, because it's a smarter lockdown in many ways. Some things are still open, and a lot of activity can continue. So that is dampening the impact, of course, of this second wave. In terms of employment, there is the largest impact is expected to occur now, with a rebound later on. So there is a big impact that is mitigated by the specific measures that are taken to sustain the impact on individual firms and people, independence. But what we've learned is also that the behavioral change that is voluntary is very important, and that was also what the question of Matthias was hinting at, I think, earlier on, is that the impact on the macroeconomic consequences of voluntary behavior is very large, can be very large. This was demonstrated here, where they made a comparison between Denmark and Sweden. And in Denmark, where they didn't have, where they did have quite a lot of imposed behavioral changes, so there was a shutdown, a lockdown, and over the same period in Sweden, they didn't have that. But you could see that the difference in total spending was not that large. That was less than 5%. And what could be observed is also when you look at the age distribution of spending by person, you could see that in Denmark, spending was less, particularly for young people who had different risk perceptions. The risk perceptions for COVID are totally different from older people. But the older people, on the older people side, we see that there was less spending by elderly people in Sweden than there was in Denmark. So because they made for themselves the assessment, probably, I think that's the reason, that they had a higher risk of consuming in an environment where everything was open, versus in Denmark, where the risk was perceived to be lower in an environment where everything was more closed. And so especially younger people had to change their behavior through the imposition rather than through voluntary behavioral change. So that's one aspect. Another aspect of voluntary behavioral change is of course the context in which you live. This is the area of sociology in which I'm not very well versed, I must say, but it is true that when you look at some of these indicators of what determines people, you can see that in Belgium, according to some of these indicators, in Belgium, people tend to have relatively little trust in others and are relatively skeptical. This is shown here, where trust is vertical and disbelief, defiance, skepticism, relativism is horizontal, and you can see we're quite low in terms of trust, while we're very high in terms of uncertainty avoidance. So we wish to have a more certain outlook relative to other countries, and a pretty high power distance, which means that we expect more than other peoples, I should say, that power is executed from a central place rather than decentralized at a local level. So there's more let's say discussion about changing things. So that determines also how much not only behavioral change occurs voluntarily, but also how much imposed behavioral change is complied with. Compliance with what is mandated is also determined a lot by social-cultural aspects. That is very hard to predict. And there has been, of course, a lot of debate about whether or not it's the virus that kills the economy or it's the measures. And there have been, in addition to what I showed earlier from Denmark and Sweden, there have been a few other studies that have looked into this, like for instance in the UK, where they, at the time of lockdown, you could see household spending already going down before lockdown occurred. And also in Ireland, you can see that well before the most restrictive measures are taken, things have been declining quite a lot. And this mostly is, of course, these seminal studies by Chetty that I'm sure you're all aware of, so I won't dwell on that too long, but you can see that the kind of consumption that is affected is, of course, expressing the risk perceptions associated with in-person services being more risky to people and therefore showing a greater impact. And Chetty was able to compare states with different policies, and he found little difference in consumption and employment between states opening sooner or later. And this is illustrated quite nicely with these graphs, but I understand you've already been exposed to this type of ideas in this series, so I'm not also going into much of the detail of that, but that's just illustrating that the risk perceptions are at least as important as imposed measures. But what does make a difference is support, especially when it is targeted at those that need it the most, of course. What he also showed, Chetty, and there have been other studies, was that support for people who are rougher circumstances, it makes especially a difference when it comes to expenditures on durable goods, and especially for lower income categories, in the highest income categories. So when these became available, that's the dashed line here, it didn't make much of a difference for the higher income groups, but it did make quite a difference for the lowest income groups. When we look at the Belgian data, this is data from COVIVAT studies, where they look at financial susceptibility, so people who are vulnerable to financial, are financially vulnerable. So for instance, have a hard time paying an unexpected cost of €1,000, something like that, along those lines. So it has to do both with income and your assets. And what we see is that some of the sectors that have the highest loss in revenue, like the horeca and the culture sector, also have a high proportion of people who are financially vulnerable. So we really have to be very, very attentive to this type of aspect, because epidemiologically, of course, these are key situations where transmission can occur in the leisure time. But at the same time, it represents an economic part, a part of the working population that is quite vulnerable to financial hardship, and we have to deal with that. And I think in Belgium, in general, we have been doing that quite well until now. Of course, can always argue about that, about where you put the accents. And I'm probably running out of time. So I also want to talk a little bit, if I still may, about the Great Corona Survey. This is something that we started at the first lockdown, the start of the first lockdown. at Antwerp with Hasselt and Leuven, where we have every Tuesday at first and every other week on Tuesday later on a citizen science survey that was open for about 12 hours. People had to self-select, so self-selection bias is unavoidable. But we do make that more representative by weighting based on age, gender, education, and province. People can participate on PC, tablet, or smartphone in all languages in Belgium. So it's not only Flanders. We have executed this 29 times since the 17th of March. And so far we have more than 2.8 million surveys with more than 2,000 questions asked. This is the age distribution of the respondents. So we had, as I said, 29 waves. We had the most success in the first wave, where we had more than 500,000 respondents. But the lowest we have is about 20,000 respondents. And currently we are slightly over 20,000. So it has been, since the summer, it has been between 20 and 30,000 respondents per wave. So we have all ages, and we ask about all kinds of themes: socio-demographic, symptoms, postponement of care, contact tracing, contacts also, teleworking, working conditions, and so on. Also financial impact, trust, psychosocial impact, and so on. Practical things like masks, catering, travel, shopping, parties, vaccine, the app. Basically, you could talk about the results of this study for a full day, I think. But let me just show you this. This is teleworking, the percentage of workers who work all days from home the previous week by household composition. It starts during the first lockdown, where you can see that people living with children are more likely to telework when the children are home, when the children are not at school. And this is something that we see recurring later on here in November. We see an inverse phenomenon like that when children are going to holiday camps or are actually in school, such as here during the summer and here in September, October. We see telework is now between 30 and 40% of full weeks of people who participate in the survey, corrected of course for different age groups and so on, and different occupations. Another thing that we measure with this survey is the evolution of mental well-being. And to do that, we use the THQ-12 score. This is a standardized measure, 12 questions about mental well-being. Here you can see, so the higher you are on this score, the worse your well-being. So higher is worse. It starts also here first measured 24th of March. During the lockdown, it increases mostly in the younger age groups. And then when the exit phase, you see a decrease, so it's getting better. It becomes worse again when in mid-July, August, the realization came that this isn't over yet. And then going into the third wave, it became much worse, especially for students. So this is shown in the top graph. This is this age group, students only, and below that is a line of the same age group, but non-students. And this is a huge difference in mental impact. So this is very, very important and very concerning, of course. At the same time, we see that elderly people have pretty stable and much lower impact on their mental well-being. The line here shows the mental well-being as was measured in 2018 in the Belgian Health Survey. It was 1.7 on average for all groups combined. We're well above that now for all groups combined. But the elderly have quite stable because they have very little uncertainty, and their social life is not impacted that much by the measures that have been taken. So that those are two aspects that are very important for mental well-being. This is, I cannot see the legend of the map that I'm showing in Zoom, but I know that the students here are still the highest up, and we have horeca, culture, and evenementen, and below that you have people who are retired. So this is also when you don't split up by age the case. And these are weighted scores by the other characteristics of the respondents. And there's a whole range of things that affect mental well-being. Of course, living alone is important. It gives you also a worse health, but this is also correlated, of course, to age and all those other aspects. One thing I'd also like to mention is, am I getting over time too much? I will.
No, it's okay, but maybe you want to wrap up within 5 minutes.
Okay, I will do so. As you see here during the lockdown, it's going up, and this is for people living alone, but also people living together with housemates. And thing we also measured was tensions in the household between the generations, and you can see that this is the percentage in each of these age groups that is reporting increased tension with another age group in the household. And you can see at the start of the lockdown, in the early parts, you can see tension here basically between children and their parents. Basically, that's what most households it comes down to. And as time progresses, you can see how this is rising. And this is an explanation why, especially the younger, have had lots of problems with their mental well-being. One of the places they may not want to be, especially if you're a teenager or a young 20-something, you might not want to be spending your entire time with your parents, of course. We also are measuring loneliness. This has also been becoming worse over time through this whole pandemic. We also have to take into account that there are big differences between people. So there is a group who have a 0 on this GHQ 12, so they have no problem whatsoever, and this has been increasing for quite a few people. It became worse again during the third wave, but still it's more substantial than at the beginning of the whole pandemic, so that people have learned to live with it. And it also shows that in normal times there's always room for improvement. So I started with the physical contacts and what it did to the health system and disease and death, but we know that risk perceptions are driving these physical contacts, but in turn, of course, the transmissibility. Mental well-being is very much dependent on these physical contacts that we are allowed to have or are willing to have given our risk perceptions. And these physical contacts also have an impact on the economy, as do the interventions, as does the demographic change from death with certain pandemics that can be much larger than for COVID. And of course, the perceptions related to the health system. So this is sort of an overall view of the interconnectedness of these different aspects that feed into each other, but the crucial thing remains this physical contacts and the risk perceptions. I just like to mention the Great Corona Study team as a final slide, and the EpiPost project, on which the modeling is related to and is coordinated from the University of Hasselt. So I hope I hope I didn't go too much over time and haven't been too superficial either.
No, thanks a lot, Philippe. Fascinating talk. Lots of topics. I have some questions of my own, but let me first open the discussion. And I think it is possible to connect people so that they can ask their question directly, orally. So who wants to start?
Voilà. There is a question coming in from Yassine Maxits, who is just thanking you for the talk. But I have a question, Professor BEUTELS, from myself. I saw in your, the big Corona survey that children were not amongst the age group that were surveyed, of course. But then again, there were detentions measured. So it's a perception of the parents.
Yes, it's mostly the perception of the parents. So we almost have no participants under the age of 13. We did have a stage before the schools were opened where we had a subsection of the survey that could be filled in by young children, but we didn't use that to inform this, what I'm showing here in terms of tensions in the household or mental well-being. But we did. So one of the interesting things of this survey is that it has a huge, there's a huge response. So it's quite remarkable for a single day survey, but that despite the selection bias, we can pick up quite a lot of useful signals. And most of the other surveys that I know of cannot avoid the selection bias. But at the same time, the survey is also, so we collect information from the survey, but at the same time, for many people, we see that the survey is also a means to express themselves. It unites people to some extent. And I think that's one of the reasons why, especially in the first phase of the pandemic, we had such a huge response, where we had more than 100,000 respondents for, I think, at least 7 or 8 waves.
Thank you. Yassine actually has a question. Yassine?
Yes, thanks, Hilde. So I was wondering, we are in crisis. We're focused on this crisis as well, and I was wondering how the surveys can help identify not only difficulties and challenges, but also opportunities, trends or strategies that might that have emerged from the crisis that might remain when the crisis is over. I think of telemedicine. I think of maybe new ways of recruiting and employment, new segments of the population that participate in a different way in society. Do you have it's a very general question. I was wondering if you had an idea of that.
Yes. Yes, we're learning all the time from this survey, and unfortunately, we don't have a lot of time to actually analyze the surveys in the full extent. So we expect to be doing research on this for many years to come. But what of course, we do, we analyze a lot of stuff, but usually it's something that is topical at the moment. And what we see in terms of telework, for instance, what we're very interested in is seeing how it improves the lives of some people, but also in which circumstances it's impossible or it becomes worse for some people. And a very general way in which it becomes worse is when you have children at home. That comes out very clear also when we measure mental well-being. And we associate that with children in the household. There's a clear interference there where telework is quite detrimental, perhaps both in productivity as well as in mental well-being. So yes, I think there's lots of things that we can learn from that, and I think so. This is also data that is being kept in a database, and people who want to analyze these data can send a request for analysis, and so we very much want data to be used as much as possible. That's also something I forgot to mention.
Thank you. Professor Buff has also, Sandy Buff has also a question. Sandy?
Hi, Philippe, this is Sandy. So I had one question on this thing about the tensions in the household, because in the end, 18 to 70-year-old is quite wide. And I think, in the end, people more than 70 living with young people is quite, rare. So it's a bit tricky here. So I wondered actually whether it's your own grouping, those three categories, or actually would you have a bit more granular information? So that's my number one question. And then I found really your results on the students, really worrying, but actually probably extremely true. And I was wondering as well, the aspect of sharing, space between students, and how actually they were dealing with the uncertainty, of contaminations, and how actually there were some worries more related to the fact that actually, if you're living with people who continue, seeing other people, whether there are some additional worries about actually, the risk of being sick, or whether it's much more, you think, related to the fact that the classes have been online, they have much less opportunities to, enjoy their student life. So how would you explain, that very increasing, negative aspects related to the general health?
Yeah. Yeah, first of all, the age grouping here is just for presentation purposes. We have the ages of people, and we are doing more sophisticated analysis than these, so we don't have to group 18, 70-year-old together.
Brilliant. That's great. Yeah, good.
Yeah. So for the students, I think the aspect of the lack of a perspective and uncertainty about their future, but you have to know also in general. So if I can go back here, if you do this type of survey in peacetime, there's also a clear age gradient. So younger people in general have worse mental well-being, also in pre-pandemic times. So because of the being young gives more uncertainty, you have to make your big life decisions. You still have to make them to a large extent. That's one aspect. But for the students in the crisis, I think this is made heavier by the fact that you have to adapt your social contact so much. And the fact that they are, as I showed at the beginning of the presentation, they are the key group when it comes to the frequency of physical contacts. They are really the core group in pre-pandemic times. So the impact of these measures for them is the highest of any type of group in terms of age. But as students also, it's a point in your life where you have to make, big decisions. Your future will be determined. And at the same time, of course, you're completely devoid of contact. I think it must be a real struggle. I try to imagine it myself being a student now. It would be, I find it very worrying indeed. And we try to, it's something that we discuss a lot when we talk about measures, is what can we do for the students? And should we give precedence for relaxation for students over, for instance,
I agree. Yeah, I agree with you. I think it's extremely worrying. And the fact is that it's almost feel like they're bearing a sacrifice. And if we just compare to the same age what our lives were, whatever our generation, it's definitely, better. So yeah, okay. Thank you. Thanks.
The next question comes from Antonio Estesh.
Hi, can you hear me?
Yes.
Cool. actually have two questions. Thanks a lot for this very, very interesting presentation. And I'm impressed by how much data you've been able to collect. I do have two questions, I said. The first one is, do you have any evidence on the incidence of the capacity constraint that you have in the system? I mean, I know lots of people who had their surgery delayed, a lot of people who had their treatment, cancer treatment delayed, have kidney, friends with kidney issues. Does anybody measure that? I mean, how much does it cost to delay by 2 months, by 1 month? Is that being picked up? And this takes me to my second question. I work on infrastructure, I mean, on transport, electricity and stuff like that. And when we think about these sort of issues, actually, we rely on peak load pricing, basically. How do you do that in health economics? How do you think about the fact that you need to pick up the fact that more pandemia issues are going to come up and that maybe we need to increase the capacity, but somebody has to pay for it? Thank you.
Yeah. Yeah, that's a very relevant question, of course. At the moment, as you know, you probably have heard, in Belgium, it's very hard to get data very quickly. So at the moment, I don't know who's collecting this and who's having access to this. But I assume we will start to see it when the data become accessible on the activity in hospitals through the reimbursement of medical acts. So that's one way. So the Intermutualistic Agency collects this information, but that becomes, it's not available to me at the moment anyway. So I can't say with certainty who is actually looking at these data at the moment. So which elective medical acts are being postponed, and what does this postponement mean in terms of the health detriment associated with that? That still needs to be analyzed. I think I assume some other people are working on that, but I'm not myself. I don't know.
But it should fit into your assessment of the capacity requirements, right? At some point.
Yes, but we're not saying how much capacity would be ideal.
Maybe that's a fair question, isn't it?
Yes, that's a very good question. It's because when you increase the capacity, it's a community, it's a circular discussion a little bit, in the sense that if you have more capacity, you will allow a bigger wave in some sense. That's actually, in Belgium, we had a bigger second wave than the UK has now still, I think, or that what seems the case at the moment, or the peak is almost the same. But they are having much more problem because the base capacity is lower. And I wonder if we had a lower capacity in Belgium, because we have one of the highest capacities in Europe in terms of intensive care beds, whether or not we would have been more cautious, I don't know. And another thing is, the base capacity that you need in peacetime needs to serve another purpose than just the pandemic preparedness, I think. It needs to be a comprehensive plan.
No. I think we agree, but these are choices that I think need to be explicit, in a sense. I mean, if you have an health issue, you know, right now in Belgium, even if we have a very good capacity, delays to be able to get an X-ray can be quite long, for instance. And these sort of issues are the sort of stuff that I would sort of imagine somebody has to think about, but again, maybe this is not the right time. I'm just curious about my second question. When you start thinking about capacity, how do you pay for it?
Yeah, I think this has to come from solidarity, from a solidarity payment. It has to come from the taxpayers' money, basically.
That's a choice, right? I mean, either we go for a user fee, which includes a peak load pricing strategy, or we go for subsidies, right? But who runs the discussion actually in Belgium?
I don't know. I don't know if this is being discussed.
Yeah, fair question, no?
Yeah, absolutely. So the work that I showed about this is more like taking stock while things were happening.
Okay.
And also the work that we've done in pre-pandemic times had two purposes. It's just to show that this will be a huge problem for the economy. Mm-hmm. So you better be willing to spend more than what you usually do for prevention. That was that part. But it didn't have any, specific solutions, I would say. It was just trying to make health economists think more outside of their realm. But it's fair point. It's very fair point. So who is specifically looking at this? I don't know.
Well, the team maybe will do that for the future. Lives on. Thank you very much for this. And by the way, thanks a lot for making me feel so old, because if I look at the level of tensions I go through, I belong to the over 80 years old category in your group. Thank you. Bye.
Thank you. Michel, you also had a question?
Well, it's a bit in line with the discussion. First of all, good morning, and thank you so much for your contribution to our seminars. You know, this question about who is paying and, how do we organize to cover this cost and to prepare ourselves, do you really think that this is a question to be addressed at the Belgian level? I'm quite surprised to see how much we keep discussion ongoing inside our country, or sometimes even inside each region. So my specific question is, I mean, your work is really remarkable. I was wondering how much you exchange with other colleagues across Europe doing similar studies, and whether you will come out with, I would say, more global picture at the European level.
Yeah, that's of course also very relevant. So the work that we did pre-pandemic times, there were two European Union projects. So we were in constant collaboration with other European researchers, and we fed back to policymakers at the European level. And I'm now talking about 2008, 2009, 2010, about, you have to be prepared for this. The impact is huge. So that was the project Polymot and the project SARS Control. SARS Control was a project that was started after SARS 1. So it ran from 2006 to 2009 or something like that. Yeah. So that was, the intention was to get something moving also at the European front. And you're completely right. We shouldn't be thinking about this for Belgium in isolation. And now also we are working together with our colleagues at the London School in London, in Holland, in France. We're trying to collaborate all over Europe in terms of the models. In terms of the mental well-being, at the moment, I must say I'm not working internationally on that. That's more a Belgian project at the moment.
Thank you very much.
Thank you very much for this very interesting presentation. Also for such interesting data and results. So as you shown in one of your slides, risk perceptions are crucial for this pandemic. I can imagine that they're very difficult to measure because they are perceptions. I was wondering first if something should be done currently to change some of these risk perceptions. I can imagine that there is a part of the population that perhaps has a perception which is that perhaps the risk is much higher than it should be, which has a certain type of impact, namely, I think, perhaps in mental well-being, whereas other type of the population might perceive the risk as being too low, which might actually result in more contagion among the population or the like. So my question then is, should it be reasonable to expect that these perceptions should somehow be changed? I don't know if by the government or some kind of policy measure to try to educate people better about these risk perceptions. And also whether do you believe that this type of risk perceptions, in particular those who believe that the risks are perhaps higher than it should be, also the graph that you just showed right now, with the differences in age categories, could this also have an impact on their mental well-being? And the reason why I was asking this is when you actually show the graph, considering that the age group, older age groups should have a higher risk, I was expecting that they perhaps perceive the risks as being more risky, and this would also have a negative impact on their mental well-being. Thank you.
Thank you. That is also, of course, a key component. When you look back at the literature also of risk perception driving the demand for infectious disease prevention, and some of the studies we've done ourselves also with discrete choice experiments, but also with other types of design, we see that risk perception is prevalence elastic. So it's very much driven by the prevalence that the person observes for himself, for his family, and particularly the severity of severe outcomes. And in that sense, it's true that younger people should have a lower risk perception than the older people, but the impact on mental well-being, I don't think is much driven by these risk perceptions in this crisis. I think the impact on mental well-being is more driven by the lack of physical contacts for most people. And I think that also creates a tension between what I do for myself and what I do for others. People are reducing their physical contacts because they feel an obligation towards others. It's not because they have the personal perception of their own risks. I think that dominate the perception they have of the risks to others. I think most people are aware of this, but changing the risk perceptions of people way is very difficult. The main thing is indeed to communicate in transparent ways about risks associated not only with incurring infection, but also the severity of disease given infection. And this has changed quite a lot under the influence of discussions in the media and also in the science. We are evolving in terms of what we understand. And we also, what we see in our survey is that people with underlying illness tend to have a higher impact on their risk perceptions and on their mental well-being. And that goes through all the age categories. So because underlying illnesses, we can look at it through all the different age categories. What else? There was something else I wanted to say, but I slipped my mind now. Yeah, how?
No, that was very interesting, and at least to my part of the question, it did answer. So thank you very much.
Okay, thank you. Yeah, one thing I wanted to add also is that the contact data that we measure, so the physical contacts in different stages of the pandemic, we also measuring risk perceptions of these people. So what risks they see for themselves. And there we see there's a clear association between the number of physical contacts that they have, the circumstances in which they have these contacts, and the risk perceptions. So, but changing risk perceptions of people is very difficult.
Okay, well, thanks a lot, Philippe, for a great presentation and very interesting questions. Maybe I can ask one last question and then we have to close. I think all this data about the great Corona survey, and it is great indeed. It was. My question is how, in terms of, and of course, we are in a political process which is a bit chaotic because people are super unhappy, and then it's and everybody's lobbying and so on. So it's not like the typical economic social welfare maximization thing, where we try and design thing as a benevolent planner or whatever. But still, I think as economists, we always want to try and find a narrative whereby we are, trying to do our best. And I guess one narrative I could have about the recent policy is, okay, we are trying to prevent a third wave, which would be a disaster for everybody, including economically, socially, mentally, sanitarily, and so on. While on the other hand, trying to give precedence to keeping schools open. I think in Netherlands and Germany, schools have been closed for 2 months. And I think it makes sense in the sense that you can close a shop and give money to those who don't work anymore, while you don't give money to kids because they don't go to school. I mean, that doesn't work. So now, at the same time, it's clear that this message that we are trying to help our youngsters, well, it doesn't prevent this picture, which is is there, that they are really unhappy still. So now, by the way, when you hear stories, not everybody is unhappy in the same way. There are kids who, I understand, are happy not to go to school or university anymore because, they were not very popular and they might even be harassed and so on. It's not trivial. Harassment in school is not trivial. Now, do I read well your slide about the fact that you have confidence intervals, and therefore what we see here is that almost all, or 95% of the youngsters are unhappier than the other groups, so that it takes care of my my problem. And by the way, also we know that perceived, self-declared happiness is basically lowest at 40. I guess when you have young kids and the like, and they make your life difficult, or not so young, but and then they are much higher, so at younger ages and at later ages. Now, is this correcting for this? It's all unhappiness relative to the normal ones, or is it absolute?
Yeah, my connection was lost for a few seconds, but I think I got your question. You asked about the confidence bands.
Yes, is it for example, should we read the picture in the sense that all the orange category, all the people, or 95% of the people in the orange category, age category, so was it 18-25, are less happy than the 95% of the other age categories? And second, is this happiness relative to the usual happiness, or is it more absolute?
Yeah. So what we try to do when we make comparisons between groups is to have a multivariate analysis. So we're controlling for age, educational attainment, province, and gender at all times. So when we're looking only at age here, when we split it up by age, then we are controlling for educational attainment, for province, and for gender. The confidence bands is something that we're actually still working on at the moment to get these better, because this, of course, we were kind of reluctant in the sense that it's kind of deceitful. because of the selection bias. And so we're trying to, because it can create a false sense of confidence, ignoring the self-selection bias that we undoubtedly have to deal with. People have to choose to participate in the survey. But what it shows is indeed that the differences are significant between these groups when the shaded area doesn't overlap, basically. And most of that, the narrowness is driven by the size of the groups that are participating. So we used 80 plus at the bottom. That's relative to the other age groups. It's not a large group of respondents, hence much broader. And also when we split up an age category in students and non-students, we lose a bit of the confidence there as well. That's why we have these broader bands. But it is also, it's a nominal measure. So the GHQ-12 is a standardized score. It's used quite a lot in this type of research. It has 12 questions. Only one question is about happiness, I think, if I recall well. So it is nominal. So they are, but you can compare them between each other, I think. And given the selection bias in the survey, we also tend to focus more on the evolution than on the relative differences at any specific point in time. But clearly, the overall conclusion that students are suffering the most, I think, is quite robust.
Okay, thank you. So once again, thanks a lot for a very nice presentation, discussion. Thanks to all who asked questions also, and see you soon.